you very much for the introduction, and thank you for the invitation, Green. It's a pleasure to be sharing some insights with all of you. First, I would like to mention that I have no conflict of interest regarding to this presentation. Well, the talk about today is about the muscle building supplements use among men in general, and my research has been focused on Latin American men. So the idea is to introduce the use of muscle building supplements as a mean of control weight in shapes in the context of eating disorders among men. And first to start, I would like to talk a little bit about a very groundbreaking publication that came out in 1993, where researchers were looking for the psychiatric effects of steroids used, and as many times in science, they discover an unexpected outcome. Close to 10% of the participants, even though they look large and muscular, they felt like they were weak and not muscular enough. And according to the researchers, this syndrome, which they name anorexia nervosa, resembles eating disorders in many ways, in many body checking behaviors, appearance avoidance behaviors, very strict dieting, compensatory behaviors. So at that time, it was believed that all the men that were not captured by traditional measures on eating disorders was because they were receiving a social pressure toward muscularity. And reverse anorexia, it appears to be like the male analog of anorexia nervosa among men who wanted to be bigger, as this was evidence in the gym subculture, bodybuilding magazines, and many Hollywood movies with bodybuilding heroes. So at that time, it was believed that anorexia nervosa was driven by a desire to be thin, and it has affected to young women, while reverse anorexia was driven by a desire to be more muscular, and this was most likely to affect on men. So there were differences in the social pressure and social expectations that men and women receive on the body ideals. Later on, this syndrome was classified as a type of body dysmorphic disorder, but this was I'm a great spoiler of my own presentations. So this was due because whenever they assess the individuals suffering from reverse anorexia, later named muscle dysmorphia, and they use traditional measures, scores of people with muscle dysmorphia did not differ from scores with people without an eating disorder that much, since traditional measures were most likely to assess thinness-oriented forms of disorder eating. And since this type of disorder eating was not present among this individuals, it was thought that reverse anorexia should be most proper consider a form of body dysmorphic disorder rather an eating disorder. However, later evidence suggests that it's better to consider muscle dysmorphia as an eating disorder. Their main clinical features are concerned with muscularity, extreme anxiety if deprived from physical exercise, strict diets, a lifestyle around physical exercise and diet, a health risk combination about substance use, diet, and exercise, avoidance and appearance checking behaviors, and deterioration of interpersonal relationships. Sorry. We're going to be a little bit more focused on the concern of muscularity, the strict diet, and the health risks combination of substance use, diet, and exercise throughout this talk. So what we understood about eating disorder was mostly driven by a desire to be thinner, and there was a pursuit of a thin ideal, a fear of gain weight, a restricted and rigid dietary patterns, presence of purgative compensatory behavior, and substances that they were used, they were most likely to be diet pills, fat burners, amphetamines, or some sort of stimulants. Where on the other hand, muscularity-oriented disorder eating is characterized by the pursuit of the muscular ideal, a fear of being weak or not muscular enough, and although there isn't a restricted pattern, you will see a very rigid dietary patterns, dietary rules that are going to be around protein intake, aiming to gain weight in terms of muscle mass. There's also an excessive exercise, which is the most common, one of the most common compensatory behaviors. And we have a wide variety of substances that are being used by people who are preoccupied with their muscularity. I wanna develop further muscle mass. Those substances are divided between pre-workout supplements, protein supplements, creatine, energy drink, steroid and synthetic oils. And I'm going to be making short mention about this last two at the end of the talk. So as I said before, the traditional measures like the eating aptitude test or the EDQ were most likely to assess a sort of eating disorders, which I like to call them the traditional eating disorders, which are driven by this pursuit of muscularity. And this are some sample items, like, for example, avoiding eating when I'm hungry. I'm preoccupied with a desire to be thinner, feel extremely guilty after eating, feel that others pressure me to eat. And for example, in the EDQ, have you gone for a long period of time without eating anything in order to influence your shape and weight? Have you had a definite desire to have an empty stomach with the aim to influence your shape and weight? Or have you had a strong desire to lose weight? This would be very accurate if we are going to be assessing thinness-oriented muscularity, thinness-oriented disordered eating, but will not be very sensitive and will not capture the muscularity-oriented disorder eating. For example, if we compare this, these are two paper norms on the EDQ. The EDQ has some issues regarding to its underlying factor structure, but I won't get into that. One thing I like about the EDQ is that it, in addition to attitudes towards eating disorders, it also assesses behaviors. And if we compare women being the blue and orange are representing a man, if we compare the regular meaning more than once a week for the last four weeks, if we compare the presence of the behaviors, objective binge eating and excessive exercise, although there's a higher percentage of men who endorse on objective binge eating and a higher percentage of women who endorse in excessive exercise, differences among gender are not that significant. If we look at the dietary restraint, the difference is significant across gender, which makes sense because a woman will be aiming to lose weight through dietary restraint patterns. And there are some features of dietary restraint that are common to muscularity-oriented forms of disordered eating. And those features are most likely to be that both of the people who are following either thinness-oriented or muscularity-oriented goals or disordered eatings, they will have strict dieting. But one thing that I wanted to highlight is the few proportion of men that endorse into perking behaviors. And someone who is aiming to gain weight will be most unlikely to endorse to perking behaviors. Why am I mentioning this? Because many times during assessment and sometimes first times assessments, we are very much concerned on the typical eating disorders, compensatory behaviors, and when we see none of them, we may arrive to a different conclusion that if we see those. But what I would like to point out is that among men, purging behaviors are very unlikely, and this is mostly due because the body ideal pursuit, it's more about gaining weight than losing weight. So one thing that came across in the field was that if we were asking the right questions when assessing men with eating disorders, and it is believed that men with eating disorders are being underdiagnosed, undertreated, and misunderstood. This may be most likely because we are looking people with a similar perspective. We're using the same perspective with different populations, and we need to adapt what we're going to be paying attention during assessment, depending on the population that we are working with, or the body ideal which is pursued. An example of this is this is the first study that I published in IGED, and we use simultaneous two types of methodology to assess whether people were at risk for developing eating disorders, in traditional eating disorders, meaning anorexia, bulimia, or binge eating disorders, or subclinical forms of eating disorders, versus muscularity-oriented forms of disordered eating. So we use measures that were meant to assess traditional eating disorders, and the proportion of participants at risk when we use traditional measures among male populations, the at-risk population was close to 4%. But on the other hand, it was quite of a surprise for us that when we use measures that were most male sensitive, more muscularity sensitive, the at-risk population for developing muscle dysmorphia, or sometimes I use muscle dysmorphia and muscularity-oriented disorder eating as synonyms. There are some nuances that we can further discuss, but I'm going to use them kind of as a synonym. So when using traditional measures, we are only able to capture a very small proportion of men with eating with disordered eating. But when we use specific measures that are oriented to capture concerns about muscularity, the population at risk increased significantly. One of the things that we have seen is that among men who are at risk for developing muscularity-oriented form of eating disorders, there is lower self-esteem compared to controls, even a lower BMI. Remember that one of the concerns of muscle dysmorphia was being weak and not muscular enough. So it was kind of common, and I have seen this through my research, that men who have a lower BMI may want to increase the BMI. But also you can see among men with being at risk for muscle dysmorphia, higher eating disorder pathology, even though we were assessing through a traditional instrument, higher social anxiety, higher body dissatisfaction, and this was assessed through the MBUS, which is the male body attitude scale, and higher supplement use. This was my first research among men, and supplement use started to appear as something common across many other research that I have conducted. For example, in a paper which was first published online in 2018, and I think it got published, it got into an issue in the Men's and Masculinity Journal last year, we suggested an integrated model of eating disorders and muscle dysmorphia, and we've seen that that muscle dysmorphia and eating disorders, they share many common risk factors. It was interesting to see that BMI was a potential risk factor for both eating disorders and muscle dysmorphia, but the sense in which they were contributing to the development of eating disorders, the direction, sorry, in which they were contributing to eating disorders and muscle dysmorphia, they go from an opposite way. Having a higher BMI will have someone being at risk for eating disorders, and having a lower BMI will contribute for the development of muscle dysmorphia. But interesting and related to this talk was that food supplement, the use of food supplement has been associated with the presence of a muscle dysmorphia or muscularity or disorder oriented eating features. If we compare the proportion, this is unpublished data that I've gone through last night. I wanted to check what was the proportion of regular use, and here I have operationalized regular use of someone who was taking supplement use. And I haven't been making any distinction among supplements. I'm now on the design phase of a study. One learns a lot of its own previous research. And a thing that I have learned is that I have to discriminate across supplements because there is a wide variety of supplements. But this data does not discriminate among supplements. So weightlifters, almost a little bit more than 25% of weightlifters were under supplement use. They were using supplements at least twice a week. And this percentage did not reach the 10% among college students. So since we already know that supplement use makes its own contribution to muscle dysmorphia, we are most likely to find at risk individuals among the gym subculture and across weightlifters. When I've compared users and non-users, supplement users and non-users among men who exercise, this is data from weightlifters in Buenos Aires. And I have compared them using the muscle dysmorphic disorder inventory, which has 3 subscales. The first is the drive for size, appearance intolerance, and functional impairment. Users are non-users did not differ in terms of appearance intolerance, but they did differ in terms of drive for size, functional impairment, the total score of the MDDI, and also they did differ on eating disorders measured by the global score of the EDQ. What it's interesting to appreciate is that the higher effect size was found for the functional impairment. So there's some significant functional impairment being associated with the use of muscle supplements. An important thing to consider is that there has been some evidence that support the transdiagnostic perspective of eating disorders for muscularity-oriented forms of disorder eating, so that muscularity-oriented forms of disorder eating also share an over-evaluation of shape, weight under control, but the restricted diet may not present as food restraint. People are not restraining how much they eat. It's restricting around a rigid dietary plan, most likely to be based on protein intakes. So people will not fast in order to control their weight, but they will rather eat in very short periods of time in order not to interrupt the protein intake. It has been also suggested that the adherence of this strict diet may, and also the change in mood may also lead to binge eating behavior as seen in women, and compensatory behaviors among men may not fall under the same spectrum of behaviors that we've seen in women. Men are more likely to work out as a compensatory behavior. And I think we still have to understand the role of supplement intake, because supplement intake is something that people would do on their daily basis. So I'm not 100% sure if we have to consider the supplement intake as a compensatory behavior or as a part of the dietary plan and dietary strict plans. And because I know we have a very short time, and I want to leave some time for the Q&A. There is a big alarm and warning sign that I would like to make. As mentioned before, protein supplements are widely used among men, and they're most likely to be used among those men who weight lift. But people who develop muscularity-oriented forms of disordered eating may go into a severe phase in which they will be using steroids or synthetic oils as Synthol, for example. The thing about muscle building supplements or creatine use is that in some
looks like Dr. Compte's internet might have frozen. I think it may be him, but I think he's going to pop back on in just a moment. So I would say for everyone, think about the questions you want to ask. Ah, great. Emilio, we lost you for a minute. Maybe you could just repeat what you said.
Yeah. Can you see me?
Yes, you're good now.
Yes, I don't know what I was saying when you lost me.
You were saying that synthol is very dangerous.
Yes. What synthol this should be an alarm, because people who will go under steroids, they will have some psychiatric undesired effect that may affect the course of treatment. And I'm not sure that we are going to be able to treat them under an eating disorders approach. They may need some substance abuse approach. And the problem with synthol is very problematic. With synthol, men inject their oil into their arm, and they get their arm to grow. But it's not grow as a consequence of muscle building. It's grow as a consequence of your injecting a synthetic oil into your body. So people actually shape their bicep because they're shaping the oil. The problem with symptom is that it may encapsulate. And if it encapsulate, you at some point, you're gonna be at risk of losing your own arm. And one of the things that I have seen through my clinical practice is that people that have adverse effect with synthetic oil, they don't tend to go and see a mental health care provider. They may see someone else in the clinical field who's not aware that the synthol use is within the spectrum of eating disorders and body image concerns. So some final conclusions, because I know we're running out of time. Supplement use has been associated with the development of muscle dysmorphia, and traditional eating disorder measures do not capture supplement use. Despite of that, that's supposed to be a T, supplement use has been also associated with eating disorders. There's a high prevalence of supplement use among weightlifters, and the strongest effect site was associated to functional impairment. And there's a need of longitudinal research to understand the long-term effect of supplement use. We know that some creatine is associated with some heart failure or heart disease, but we are not aware of if there any long-term consequences of the creatine intake among young kids, sometimes kids under their 14 years of age, who are in the development phase of their life, if they will have long-term consequences due to the continuous intake of, for example, creatine. And also, it's important to take into consideration that treatment options may require some specific adaptations. There has been some suggestions that for those individuals who will suspect that the treatment will stop them from exercising, they will be reluctant for treatment. So let's not pathologize physical exercise. But I'm not sure if someone who is going through treatment can also be under supplement use. This is a question that research and clinical practice I hopefully will answer. And thank you very much for your attention, and I'm open to any questions that you may have.
Wonderful. Thank you so much, Emilio. This was fantastic. Really appreciate your coming to speak with us today. And after giving another talk yesterday, this was fascinating. So I want to open it up for questions. Please feel free to put your questions in the chat. or if it's easier to unmute and share your question that way, that's fine too. Looks like we have one in the chat already from Ariel Betcha, postdoctoral fellow in the division. The question is, do you have any advice for eating disorders researchers working with secondary data on the best ways to capture relevant eating disorder behaviors among boys and men? So what should we be looking for if we don't get to choose what we collect? We're working with secondary data. What would you highlight?
Well, that's the thing. The problem with secondary data is that maybe muscularity-oriented forms of disordered eating have not been assessed. So what I would be looking for example, would be differences in between the current BMI and the desired BMI. Since muscularity-oriented forms of eating disorders are more likely to have a higher desired BMI rather than a lower desired BMI. So there may be data on current BMI and the expected BMI. However, we have to be cautious when using BMI when addressing muscularity-oriented forms of disordered eating, because a BMI of 30, a BMI of 35 or 40, we may think that we may categorize that person as obese. And bodybuilders who have a large muscle development, they tend to have very high BMI. So if possible, if data is available, try to calculate the fat-free mass index. It's a formula which is included in one of Harrison's spoke paper, or you can reach out to me and I can send the paper later. It requires to have some the knowledge on percentage of body fat. If you do have that, you are going to be able to calculate the fat-free mass index. And in that paper, there's a threshold suggested that if the person scores above that threshold, you can suspect that the individual is under the effect of steroids.
Interesting to be able to detect possibly steroids at play in that way. We have another question, this one from Amanda Ruful, research faculty in the division, of course. She's asking if you have seen in your research any differences in the patterns on eating disorder symptoms, body dysmorphia, supplement use across race ethnicity groups, whether that's your work in Latin America or in other samples.
Well, this is a great question. Latin America is a very particular population. We have most of our population living under the line of poverty. So what I would say is that the differences are not cultural in terms of the country what you are living, because many Latin American cities are Western countries like Mexico City, Buenos Aires, Santiago, Bogota, Rio de Janeiro, Sao Paulo. Many cities, they are more likely to have eating disorders, are more likely to have the same presentation that in the Western English-speaking countries. The thing would be differences with access to food and storage to food. So I would say it's rather than a cultural or race differences, there would be like socioeconomic status differences. People from middle, upper, and upper classes, they are more westernized than people from lower classes. So I would say that this is much more related to socioeconomic status.
Good, very helpful to hear that. Thank you. Another question in the chat came in. Stacy Shelton, who's another visiting scholar with Striped right now, is asking about what regulation is like for supplements, or specifically the muscle building type supplements in Latin America, whether Chile specifically or other places. What do you think of that regulation? And is there any kind of protection for minors from these products?
Uh, um, well, actually, this is a great question. And what sometimes is a great opportunity for researchers, it's a flaw in society. So there is the only regulation that there is, it's for steroids. Steroids are meant to be used in the treatment of some type of cancers. And if you're going to get steroids out of the pharmacy, it's very difficult. You have to go through a lot of bureaucracy. But cancer patients who need steroids in their treatments, they will get it. It's going to be very difficult for someone who's not under that clinical condition to get steroids. However, having said that, that's the only regulation that exists. People are able to get steroids out of in the black market, and they're most likely to get steroids from gym coaches and from the muscle building pre-workout supplements. There is no regulation, not any kind of regulation. I always tell the same story. When I was living in Buenos Aires, I lived very close to a store that sold antiques. It seems that they were not doing well in business, and they started selling pet food. So it was kind of a weird combination between antiques and pet food, but okay, we are in a free country, you can do whatever they want. But and suddenly they moved to a supplement store. So they were selling at the same time supplements, pet food, and antiques. But it looked like they were doing very well with supplements, that they stopped selling antique, they stopped selling pet food, and they only sold supplements. So we're starting to see, and people are able to purchase supplement use from everywhere. So the long story short of this story is that you can even buy muscle building supplement use from antique stores. So you can buy them anywhere at any age. There's no regulation. We don't have any longitudinal data of any possible adverse events of continued use of this type of supplements. So this is a whole opportunity for us, but sadly, it's a gap of knowledge for the patients that we are seeing.
Wow, that's kind of chilling to imagine. But certainly the US is very similar that way, and you can buy these products anywhere with no age restrictions. We have a question from the clinicians. Melissa Freisinger is asking for when someone may show up at the emergency department having abused synthol, what do clinicians need to be aware of? What are the signs?
Signs with synthol would be like synthol will encapsulate, and that will affect the circulation of blood in the arm, and at some point you will have no blood circulation in some areas. And if this is a very severe condition, people may have their arm amputated. But I think that just the fact that someone is using synthol, despite they get the oil encapsulated or not, it's a huge red flag. I think the good thing that I'm getting the opportunity of giving all this talk, and I thank you very much, Brim, for this opportunity, is that many physicians are not aware of this condition, and they may treat the consequences of using a synthetic oil, but the underlying mental health condition, it will go unnoticed. So the person, and there are some videos in YouTube. I didn't want to share those videos because they are very like personal videos, and there is some privacy I don't want to overlook, but there are some videos in YouTube when the Synthol users, they say that they became addicted to this type of substances. So either if it is a substance misuse disorder or a severe eating disorder condition, I think that other people from outside the eating disorder field has to be aware for them not to treat just the adverse consequence, but to refer that individual to a psychiatric assessment.
Wow, great advice. It sounds like really helpful. Now, we just have a couple of minutes left, and many of the clinicians on the call now are working in our adolescent young adult clinic. I'm wondering if you have advice for what our clinicians across the different disciplines or professions should be looking for, especially with boys and young men who may come through not with a specific complaint that seems it's obvious for synthol or steroids, but where body dysmorphic disorder might be under there could be use of steroids. What advice do you have?
I think it's very hard to work with adolescents at this time with such a great influence of social media, when we have such a strong messages from social media, TikTok mostly, or Instagram, that it's sending a message that you must have a six-pack, or you won't worth anything if you don't have a six-pack. And since this muscularity-oriented form of eating disorder, it's not included in the disease classification manual, it is not a shared conceptualization that this is a problem. And many teenagers receive a lot of positive reinforcement from their families and friends, because they have a presentation that from someone outside the field, they are having healthy habits. They are eating healthy food. They are doing exercise. But and if we try to go against that, we're going to lose the patient. If the patient's going to suspect that we want him to stop doing exercise, we're going to lose the patient. I think we have to be very cautious when working with adolescents, and we always have to have this pros and cons. And I remember when I used to work with clients, I wouldn't discuss my clients their line of thought. What I would ask them is it working? Is it working for you? Because you have all the strategies. I won't say no, I won't say anything against your argument. If you want me to tell you that you are on the right path, okay, you are on the right path. But my question is it worth it? And let me just finish with an example. I was running a study, a double-phase study, where I had to screen and then interview. And I had this guy who was clearly going through a muscularity-oriented form of disordered eating. And I asked him what was the main purpose for him to wanted to be bigger. And he said he wanna have more dates with women. And I asked him, okay, is it working? And he suddenly stopped talking and started thinking, and he said, no, it is not working. I'm not going into date. I'm afraid to go into date. I'm anxious about going into date. And if you had the chance to look at him, he was very good looking. He had a great body, but he was much more anxious of socializing than his premorbid condition. So don't argue against them, because adolescents are going to be right. They were like a minute away from a Nobel Prize. What I would ask them is it working? Are you able to get your goals, to reach what you want to reach? And through the social and the functional impairment, it's how I get to conceptualize that they had a problem. It was their functional impairment which helped me conceptualize that they have a problem and they were not reaching that goals. That's what I would suggest.
Great, great example, really clear there about reaching them where they're at and then talking through and how, like you said, how is it working? Well, thank you so much, Emilio. It's been wonderful hearing about your research and your observations as a clinician, and sharing a lot of wisdom with our team here in adolescent medicine. So I know we're out of time, so I'm gonna let everyone go, but if questions come up later and you'd like to follow up with Dr. Compte, just let me know and I can put you in touch. So thank you so much for a wonderful presentation, and thank you everyone for joining us.
Bye-bye.
Bye.